When we look at an orthodontic patient, the first thing that we want to do is to so-called make a diagnosis. Technically, a diagnosis is determining the nature of a disease or the decision reached regarding that disease. Now, as I tried to say the other day, when the idea of the norm concept emerged, the diagnosis involved the determination of the differences from that patient from an ideal. In other words, you have this idea of a perfect face. In other words, the perfect Japanese face by your genetics. Now, the nature in which that patient deviates from that is, in one way, your diagnosis. Now, the second part of the diagnosis is the determination of the etiology. Because the mother will sit there in front of you and say, now, doctor, what caused this? It's like the little child who was had terrible bad grade cards, and his mother told him that night he's going to have to answer to his father because of his bad grades. So he called his son in, and they sit down, and he said, now son, I understand you have some bad grades here. And his son looked at him and says, yes, father. He says, what do you think it is, genetics or environment? When the mother asks, you answer the question.
では母親に聞かれるわけです。それに対して質問に答えます。
Etiology of a malocclusion is a combination of genetics and environment.
全く同じ状況です。
It's obvious that the child has a tongue and a lip problem, but we all also know that those muscle patterns, those habits, can be an inherited phenomenon. I mentioned the fact that patterns can be inherited. Okay, so a part of making a diagnosis is twofold. One, determining the nature of the departure from normal, and the second is the looking at the etiology. That's part of your diagnosis. Now that, in our thinking and in our teaching, stands off by itself. In other words, that's a separate entity. When I was in school under Downs, we spent one morning with one patient. In other words, every single patient is a whole research project. All you need to do to show that is to start studying a comprehensive computer printout on one patient. And you begin to appreciate how really individual each of us are. Now, we want to clarify that so it'll be clear in your thinking when you sit down and start looking at a patient. Now, the second part of what you have to do with the patient then is the so-called prognosis. The word prognosis in the dictionary says the foretelling of the probable outcome of a disease or some condition or infirmity, so forth. Now, what does that entail in our field particularly? It was very obvious looking at some of those class 2s that as far as the jaw relationship, there was an improvement.
There was.
Yes. In many of these class 2s, there was an improvement in the jaw relation. We did find 2 in that sample, one of which was my own, in which the patient was a definite class 2 and without treatment became a class 1. One of the patients was class 1 and almost went class 3. A couple of the patients were class 1 and then went class 2. So it seems as though the development of the occlusion is not directly associated with the growth of the jaws. What does that tell us?
それで何がわかりますでしょうか?
That there's 2 parts to making a prognosis. One is the growth of the jaws.
一つは顎の発達成長を考えること。
And the other is the development of the occlusion.
もう一つは
So there's a 2-prong to the normal prognosis, and what are we talking about? We're talking about forecasting. So one of your problems when you see a child that's at 5 and just about ready to lose the deciduous teeth, the anterior deciduous teeth, and get the first molars. And if you're a pedodontist, you see these children all day long. And as an orthodontist, I would like to see children at age 5. Give me a year to make the corrections that might be needed in order to guide the first molars into a class 1 and set up the stage for normal eruption of the permanent incisors. But I have to make a prognosis now of that 5-year-old because the treatment I do may not be necessary, or more might be involved than just simple treatment. Now the next critical age, I think, is 7.5. And when I started my practice, I kept track of the age of the first 1,000 cases that came to me, or the most frequent age that they came was 7.5. Certainly by 8.5, I feel that a diagnosis should be made of the child, which then entails a prognosis of the growth of the jaws and the development of the occlusion, because that's really what orthodontics is all about. I wrote an article some years ago in the Proceedings of the Foundation for Orthodontic Research on the diagnosis of the 8.5-year-old child. I brought out several points and I discussed them the other day. Let's see if we can review them. Number 1, you can see what the likelihood of the permanent occlusion is going to be, because once the first molars come in and lock in function, they're going to stay there. As far as the relationship of the teeth is concerned, the bite is not going to change, except open bites when a thumb habit or a breathing problem may be corrected, the open bite will close. So if we make a prognosis at 8.5 of a crossbite, a class 2 or a class 3, the odds are that that's not going to correct itself. Now, based on that, then, we have to superimpose that on the development of the face. So we want to look at respiratory problems in a child at that age. We want to look at the factors that are operating in that oral environment and the relationship of the skeletal to the functional problems. We want to see whether or not there's any ectopic eruption of teeth, congenital missing teeth, and particularly impaction of canines. If we can do something to stop an impaction of a canine, we've saved about 3 years of treatment later. Because the correct treatment of an impacted canine is not a simple operation. You have to move a tooth 1.5 centimeters. It's a long way to move it. You have to make space for it, number 1. Then you have to bring it in and position it, and then retain it. So if you can prevent a cuspid impaction, it's a great service to a child. Finally, 8.5 is a wonderful time to enucleate third molars. Now the other half of prognosis is what will happen to the disease if it's treated. The first part, as I said, was the prognosis of the probable outcome of a situation if nothing is done. The second half of that is what now I call a projection. A projecting of what now the influences of treatment can do and what the probable success of treatment will be. This becomes the VTG,
これが VTG になるわけです。
a visualized treatment goal.
入ります。
Okay, now has everybody got clear what we're talking about when we talk about diagnosis and prognosis? Now, what is the connector? What must you know now to make that prognosis, or particularly to make that projection? You have to know the possibilities of treatment. If you don't believe something can be done, then you're not going to plan for it. Therefore, it's going to change your prognosis. I think one of the problems that I have in world orthodontics today is because the average orthodontist does not want to become involved in the early dentition. He'll see him in his office, and he will maybe take some records, but he'll put him under an observation list. You're not ready to have orthodontics yet. Kids sitting there looking like this.
でこうやってもう唇を噛んだり吸ったりしているのに
What do you mean he isn't ready for orthodontics?
こんな格好
Well,
して
if we
展開
treat
です
him now, we'll have it all to do over again later. And that was an answer that I was told to give patients when they came into the university.
で
Because we needed all their teeth to work with because the appliance called for it. The edgewise appliance needed teeth because it called for a full strap up. So come back when all your teeth are in and then we can do it and do it in a hurry. We can do it all in one shot then. So sorry, Mother. We'll see you later.
あの
Now what happened then in the university?
これ
What did I see happening?
どう
One floor below us in the school was the pedodontic department. The child would come in with broken teeth.
例え
That
ば
wasn't the orthodontist problems, that was the pedodontist problem.
でそれは
So they'd sit there and see these kids with protrusive teeth, with fractured teeth.
で
Well, we're going to start doing something about it. So here's what started with the pedodontist.
ですから
They started using removable plates. So they could put a patient in a bite plate and bring back, close up the spaces. So the first thing that they would be disciplined to do, based on European philosophy, was start using removable plates.
まず
And sometimes they do some benefits, so don't knock it too far. Then they started finding that they could form two bands and put a headgear on just about as good as the orthodontist could do with
それ
a little training. So then we had headgear and bite plates together. The bite plate would tip the lower incisors forward. So now they were treating class 2s. And then a little bit later, of course, the binator came in, or the activator became popular. And if it's going to work best when a patient's still growing. So all at once you had these people doing orthodontics. When the orthodontist upstairs was still waiting for them to develop
とこ
all
ろ
the
がその
teeth.
矯
And
正
it wasn't very long until this got out into the whole dental community. As fluorides came in, decay went down, and the pedodontists had to start looking for something to do. And so did the general practitioner. So we have a world problem today of general practitioners trying to do orthodontics. Very simply because they'll starve if they don't. And so I think the orthodontist is the tail that's wagging modern dentistry.
ますねいろいろと
Orthodontics was always a specialty or always a subdivision of dentistry. But now it is the central focus of dentistry itself.
ところ
So the tail now is wagging the dog.
ですから今
We say that orthodontics is the tail that's wagging the whole field of dentistry. There's a lot of dentists, particularly in the United States, are trying to do a little bit of orthodontics. And most orthodontists consider it to be a threat and a dangerous thing for the public. And they're absolutely right. They don't know what they have a hold of. Because how long does it take you to be a good orthodontist?
例えば
Even after a graduate course, a man that comes in and started to practice with me, it took him 5 years to be at a place where I felt that I could go on a trip, go on a lecture trip, and come back and not see mistakes made. What are you doing here? Look at the concentration of information you're getting here in this 2 weeks. It will take you 2 to 3 years to absorb what I've exposed you to right here.
今
So to get back to what I was saying, it's my opinion that if you are a specialist, that you should be a specialist
まず
with the growing child.
と思います
Because now you have to make decisions. You as a clinician, you as an expert. And we call these value judgments. So you're going to be asked now to make a decision regarding what to do about the situation at what age. And this becomes a matter of your training, your discipline, and your professional judgment.
で
Now the next thing then that I told you about was this business of possibility, probability, and feasibility. The word possibility is the extent of anything that's been demonstrated. And that's a lot. We know that we can move a maxilla backward if we keep a headgear on for a long period of time. What is probability and what is practicality? We can learn what is likely to be probable by looking at the means of composites of treated patients. So we should be able to do what is the average type of behavior that we see taking place. So on a standard basis, that's what at least we would expect to take place. So we can use individual cases to demonstrate the extremes of possibility. Then we can use the composite of a group of patients to demonstrate probability. So this is what we're doing right now. But the final decision is one of feasibility. And feasibility is what has the best chance of reaching a successful conclusion on the basis of all of the circumstances. Now here's where your value judgments come in. Here's where differences might appear among different individuals, because all people may not value judge in the same light. These are part of your considerations. For instance, 10 years later, after a malocclusion has been treated, the amazing thing to me is that patients can't even remember the orthodontist's name that treated them. Ask mothers that have been treated orthodontically what the name of their orthodontist was. Some of them can't even remember where they were when they were a child growing up. But what they have to demonstrate is whether or not the teeth are straight. If the teeth are straight, the orthodontist did a good job 10 years ago. But if they're not straight, it doesn't make any difference. The orthodontist did a bad job. The fact that they couldn't afford to have all the appliances placed at that time and the job finished makes no difference. I went to the orthodontist and look, he did a bad job. He might have tried to treat only one arch, lower teeth crowded, but he never treated it. But they forget that. They forget that they sat there and argued about, or their mother or father may sat there and argued about how much it was going to cost, and if there's anything cheaper that they could do for them. So full braces may not have been feasible at that particular time, but the point is 10 years later it makes no difference. So these are the parts of the value judgment that comes into orthodontics. And these are the feasibilities that you have to consider. Now, what is the next stage? What's the next stage in this whole system of logic that I'm taking you through here? Reviewing, reestablishing now. We're about halfway through the course. What is it then? Is the next stage is how to do it. If it's possible, okay, how's it done? If it's probable, then how can I best achieve it? Now you have another problem. And this is a major problem, because the VTG or the VTO that you draw up has to now be executed. Now, very simply, here's a phrase that I coined some time ago. You must know what an appliance will do in order to know what to do with the appliance. We showed you yesterday how double utilities work. Simply taking a patient at the age of 11, opening up with utility wires, and then using vigorous intermaxillary traction. Now here's another group of patients, 22 patients. These are not quite as brachyfacial as 92 facial axis, but starting out with only 3 millimeters of convexity. Now this is a group of patients that I started at 10, and some of them, I have to admit, erroneously, I think, had headgear treatment. Several years ago, when I used headgear, it was under the idea that all I was doing was moving teeth. But even with intermaxillary elastics, we now feel that some alteration in the midface can be made. This is not the same group of patients, but another group of patients in which a correction in class 2 was made. And you can see here then that the chin grew right straight downward and forward. Point A was moved back. Notice the nose was crossing over here. Notice the upper teeth were retracted on the maxilla, almost straight bodily backward. Notice that the lower incisor, contrary to all other cases of treated class 2 that I've ever seen up until Bioprogressive, notice the lower incisor was moved lingually. Notice there was a shift of about 4 millimeters between the teeth. And how did we shorten up the lower arch? without taking teeth out. If you notice, when we got finished here, the arch depth in the lower arch was 24 millimeters. So that's just right on.
ぴったりです。
But when we look at this,
でもこっちを見ると
how did we shorten that up and get all the teeth in? By the change in arch form. Here it was before.
これが前の状態でした。
Because in class 2, most of the arch forms are tapered in the lower arch.
二級関係
It's a response to the environment. Now, I've uprighted the lower molar,
で関
brought
学
it
大
forward a little bit with anchorage,
関学大臼歯をアップライトしてアンカレッジで少し前に持って
but I
き
end
て
up taking the lower incisor back. Now, that's why I say I might have used some headgear in the upper arch here, but I might not have used very much because classically I don't. We want to have a low interincisal angle. So naturally, we were interested in what this patient was going to do. And since we had these values that we felt were pretty adequate,
で
we went in and predicted then in the time that these patients would be treated what we would expect the mandible to do with natural growth. So here it is real.
これ
Here's
が
the
実際
predicted.
でこっちが予測
And if you notice, it looks like it grew just a tiny bit more
もうちょっ
than
と
we'd expected
予
to.
想より
But it's still awful close, isn't it?
かなり
So we say certainly we didn't hurt it. So there's 2 samples of cases that were treated that were of the brachyfacial close bite variety. Okay, now here's a different group of patients.
今度はまた
This is a group of 34
34名の患者です
with high convexity,
High
deep bite,
コンベキシティハイコンベキシティでディープバイトです
and class 2.
二級関係
This was selected by a third party, so I had nothing to do with it. Now, first of all, they were started at a little bit, very close to 8.5 years of age. And they carried them through 2 stages, or 2 phases of treatment. So naturally, there's about a 5-year interval here, from 8 to 13.
8歳から13歳まで
All right? Now, here they are treated. And you can see now the behavior in 5 years.
5年
They're right down the facial axis. Now what do you see? In position 2. Backward movement of the maxilla, backward movement of the teeth,
上顎
crossing over the nose, the nasal bone bending down instead of going forward. Nasal bone naturally tips out 1 degree a year. Now with this treatment, the nasal bone was bent backward, the nose was moved backward, the maxilla was moved backward, everything in the mid-face is moved backward and downward. See it? And a part of that has been remodeling of the alveolar process here. So that's the reason I say you can do about 2 degrees or 2 millimeters of retraction of the upper incisor, and you can recontour point A from anterior nasal spine in that manner. So not all of the movement of point A is due just to maxillary movement.
したがって A
It's
点が
due
動
to
く
alveolar
のは
process remodeling. Now notice that the nose grows about 5 millimeters in that length of time, about a millimeter a year.
1年1ミ
Now
リ
here's class 2,
2級
and in this sample of patients, if you'll notice, the lower molar went back just a little bit, and the lower incisor was moved backward just a little bit. So certainly we didn't displace the lower denture forward.
したがって
Now the other interesting thing about this is that they're safely in retention at the age of 13, and that's pretty good profile.
これ
They ended up 0.2.5 millimeters ahead of the APO plane, and the convexity was moved from 7 down to 3 millimeters.
コンベキシティは7
This is port 14.3. So certainly we didn't inhibit it. It's 2 millimeters better than we'd have been predicted for if it hadn't been treated, just based on the data that we have today.
我々の今面白いと思います
Here are 15 cases
15
that were
15症例
treated with Begg therapy.
症例
Now you begin to look at them.
でこれ見てみますと
There's a 90,
90
45,
45
88,
88
age of 12. They waited till 12 to start them.
まず
With 133 interincisal angle. You look at the face and you wonder why they were going to treat it. Really, wouldn't you? Open the butt, put a lower utility on it.
科学にユーティリティアーチ入れて
Open it up, put it out here 2 millimeter, 3 millimeter, plus 3 instead of plus 1. with a 90-degree facial angle,
でこのフェイシャルアングル
facial axis
90
angle. Let's see what, they should be 60 here.
これ60であるべきなんですけどどうでしょうか。
I read 59. So it's better.
59
It's a better face than average. Notice that the facial axis has been open 3 degrees.
フェイシャル
Lower incisor has been tipped backward. Lower molar has been moved upward and forward 1.5 millimeters, which is not too bad. Look at the anchorage that was lost in the upper arch. And they finished with the lower incisor 0.5 millimeter behind the APO. Patient's face was worsened with the treatment.
患者の
This
前
is a
術後
prediction in the time frame that we would have made on this Begg cases. It looks now as if the mandible did not get its potential. See it? Now this is the information that I have that makes me wonder if rotation of the mandible open doesn't jam the joint and inhibit a little bit of its growth. Now, when I was in school, I studied a lot of the behavior of the patients, and this was published in 1955. Most of the publications earlier than that dealt specifically with the joint and the growth in there, and that's about that was the objective early. But then in 1955, I considered the greatest publication in my whole life was in 55, but it didn't get very much attention. I always felt that the March 1955 publication was, for its time, the greatest amount of new information that had ever been in the orthodontic literature. Now, I saved all these cases all this time, and so these were 15 cases, just like the Begg cases were 15 cases. So we put it through the computer, and here is the results then of the treatment that we did when I was in school. That's an opening of almost 4 degrees on the facial axis.
フェイシャルアング
Notice the downward and backward rotation of the chin there. Now these are the patients that we treated without extraction.
ルそれは
But these were treated with no headgear,
ただ
with edgewise philosophy and second order bends.
え
Now if you notice, the mandible was rotated open.
ご覧
Every degree of opening of the facial axis moves the molar back 1 millimeter in a sagittal horizontal plane.
たいと思います。
I didn't show it to you, but now you go back and look a little closer. You really don't appreciate those composites that I showed you yesterday until you begin to look at the details.
細かい
Theoretically, then, this is twice what that is.
です2倍の高さになるはずです。
Theoretically, then,
次にま
at
だ
155, 165,
165ミリ
then 1 degree is equal to 3 millimeters.
ということ
So the function of a degree
ですから
depends upon the distance the two are carried off into space. Now, let's turn this around in the face. How long is the typical facial axis? And
長さ
how
ですね
far is the typical molar away from where we're starting to measure?
それ
Almost 55 millimeters.
え
Therefore, if I move
だから
the facial axis 1 degree,
フェイシャ
how much is it going to move the chin and how much is it going to carry with it the lower molar?
Eh.
Using the pterygoid vertical as a starting reference,
PTB を基準点として測っています
as a registration.
そ
So on a 90-degree facial axis, 1 years of growth is worth 1 millimeter of forward movement of the lower molar from the pterygoid vertical. So the direction of the facial axis originally, if the pattern doesn't change, which it tends not to do on its own, now you understand why the facial pattern itself is a part of the prognosis.
でこういうこと